there's a challenge, that's also an exciting opportunity for researchers, and there are lots of important research questions. But any of us who've done research on multiple long-term conditions will know it's complex, it's difficult to do, and it's particularly difficult to gain traction in a world where medicine's so dominated by single disease structures, journals, colleges, everything single disease or system. It's so difficult for multiple long-term conditions research to really make a difference in the real world and to gain traction. So our aims are to identify pathways to impact and to implementation of multiple long-term conditions research, to share best practice for engaging and influencing policymakers, and to understand some of the challenges in achieving impact from this research and identify how we can overcome them as a research community and as funders and as policymakers, and particularly to facilitate networking between different research groups working on MLTC research. So we're going to start in a moment with a keynote talk from Professor Lucy Chappell, who's Chief Executive of NIHR and Senior Scientific Advisor to the Department of Health and Social Care. And then we're going to have two panel discussions, one with researchers who have experience of conducting and trying to apply MLTC research, and another with policymakers who can talk about their experience of being on the receiving end of research and how it influences health and social care. We hope there'll be lots of opportunities for discussion. So as people are talking and in those panels, please join in with your questions and also your ideas and your tips. And then in the second half of the event, after a short break, we're going to go into breakout rooms where we're going to ask you to identify your top 3 facilitators and one main challenge in achieving implementation in MLTC research. Now, thanks everyone who's been putting their name and role and institution in the chat. Can I encourage you to keep doing that? Those of you who've recently joined us, that would be really helpful. And before we go on to the next agenda item, Sophie from NIHR, I think, is going to do a quick poll of attendees.
Yeah, the poll should just pop up on your screen. So please just take a few moments to answer that. Thank you. The poll is just to help us to understand how useful the event has been today, and we'll be asking the same question again a bit later on.
Excellent, thank you. Let's move on. So it's my real pleasure to introduce Lucy Chappell, Professor Lucy Chappell, as I said, Chief Executive of NIHR and Senior Scientific Advisor to Department of Health and Social Care. The fact that she's given up time to come to this event, I think, really reflects how important this topic is for the health and social care system. So we're really grateful that she's given up time to do this. She's going to outline a vision for and promote the implementation of MLT research into policy and practice, and also demonstrate how everybody's got a role to play in thinking about how research is configured to have impact on policymakers. So Lucy, we look forward to hearing from you. Thank you.
Thank you very much, Chris. Really good to be here today. And actually just seeing everyone's names and roles pop up in the chat really reinforced to me what an incredibly varied and diverse group there is today. And I think that's one of the most exciting things. So I think if I think about the challenges in health and care, what you are doing at the moment in this field is absolutely one of the really important cutting edges of our science and research. I think the poll also showed where perhaps I was before I came into this role as Chief Scientific Advisor at DHSC. I think as a researcher, there has been work to bridge this gap, but today is really about helping this community to see many more of those bridges. And it's not just what happens this morning, it's what you take away and do differently as a result. I think I see as firsthand as an obstetrician, and I'm still practicing, why this matters. And I was also on a hospital visit yesterday. And in both my own field and at the hospital visit, something is shifting. So what I'm seeing is that I would normally talk to researchers and clinicians, and everyone would be in their single disease silo. And for the first time yesterday, I saw everyone talking about the importance of MLTC. It is coming so much more into the language. So I would say you're all at the crest of the wave or ahead of it. And I think we're going to need many more of you in years to come. The other thing is that multidisciplinarity that I saw from your roles, and again, that is a real strength of this system. So next slide, please. Or first slides. Thank you, Sophie, for sharing. So I just sort of want to give you some thoughts on where we are as a team. Some of you may know that I chaired the artificial intelligence in multiple long-term conditions. So this is something I was involved with and has stayed with me. So just to set out what I suspect all of you are very familiar with, which is that the health and care system doesn't really work well for people with MLTC at the moment. NIHR a few years ago ran a series of workshops with people living with MLTC and their carers, and actually the themes will be something I think you are all familiar with. The impact of stigma, that really poorly coordinated care, sometimes with good exemplars, and we want to hear more, as Chris said, about what works, what an enabler is, and how that care could be better coordinated. But still too much of our health and care sitting in these single disease silos. And then sort of the way that we've been trained, certainly me as a doctor, and I suspect many other healthcare professionals, on how we frame it in terms of outcomes, clinical outcomes that might matter to us. But we're not so good at asking what matters to you as a patient. Why aren't we designing our care around those outcomes? And I think this also talks to the sort of the very particular need to ensure that mental and physical are not seen in completely separate places, despite the fact that much of our training and care system is designed exactly like that. So if we involve people with MLTC and their carers at the heart of our, not just our policy making, but our research offer as well, and integrate all of those, I think we're going to get a much better looking service underpinned by evidence. So we know that this is also a complex challenge to policymakers. And if you look at the conversations that have been going on, say, over the summer and into the winter, into the autumn, about the challenge of winter pressures, you'll see that patients with MLTC are really crucial to understanding this. Very few people walk into hospital with a single condition and out again smoothly. So we think that there's more than 14 million people in England alone living with MLTC, and that these are accounting currently for half of the NHS primary and secondary care costs. And this isn't a finger point. This is to say this is a huge need. And we also know that if we look at our demographics, these numbers are expected to rise as we see that aging population. So if we're not on that wave now, we're going to be so playing catch up for many years to come. And just to remember that our view is that whilst it is more prevalent in older people, as an obstetrician and as having talked to the paediatric community, this is not just a disease, or this is not just a concept that is associated with diseases of older people. And we really need to look at, for example, children and young people with complex care needs, where they have to navigate everything in the health and care system and education. And also, for example, the group that I look after, pregnant women with multiple long-term conditions. So let's really include everyone and ask how we learn across all of those boundaries. So the NIHR, together with colleagues from MRC and ESRC who are here today, are really taking steps to address those needs through research. But really, if the point of today is also to join all of you up with policymakers. Let's not leave it in the too difficult box, and let's look at how looking at clustering can really be a sort of a stepping stone to helping us understand. Thank you, Sophie. So the Academy of Medical Sciences report really highlighted this concept of clustering, and I think that it's something that's going to be woven through much of what we do. And NIHR and MRC and other funding initiatives have already invested over 45 million into clustering research, and we're really seeing the fruits of that. So, for example, tackling multimorbidity at scale to look at disease clusters, determinants, biological pathways, and to sort of really get us away from the one disease, one mechanism and say, where are the sort of joins, where are the joins in this? And what we really want to do is say, where is the scientific foundation for these new approaches, working with industry so that they come with us on this journey to look at sort of how to do early diagnosis, drug development in a different way, and not just to say, well, let's go down the ever increasing polypharmacy route, but to look at smarter ways of approaching it. And then I mentioned that we invested 23 million in the artificial intelligence for multiple long-term conditions. And what I really saw when I chaired that committee was that we had two groups from an AI background, from an MLTC background, and both in the committee and in the applications, it was really striking how these groups had come together to coalesce around this one issue. And so really innovative applications. And we also put in a research support facility. That is when I started sort of getting involved in sandpits like this one, where the sum of bringing people together, there was much less of the sort of highly competitive academic environment. And I saw much more of what we've got here this morning. So both of these programmes are in progress and awards are expected to finish between sort of 2024 to 26. And it's absolutely vital that we say, so what next at this point, rather than waiting till 2024. Thanks, Sophie. So the projects within the cluster portfolio are particularly interested in working towards sort of different parts of these pathways. And as I say, it might feel sort of as if we're getting ahead of ourselves, but actually, if we built in the what next at this stage of the project, we know that we're going to be much more likely to have outputs that really stick with policymakers and really are relevant. They're what policymakers will recognise as being important and work that they can apply. So it's never too early to start that. And even if you think you're in an earlier phase, and what's Lucy talking about, make the connections that you can see today. And this is really the point of it, to say, what does that pathway look like? And the other side of this is that we have to involve people with multiple long-term conditions and the healthcare professionals who are involved, so that they recognise what are the outputs of this project going to look like. So how are we going to provide those services? How might we best intervene to prevent people developing multiple long-term conditions? How can we address the polypharmacy issue? And think about how we tackle the harm from medication, particularly when you see more than one condition. Thank you. So we've thought about this left to right pipeline, and some of you will be familiar with the valleys of death. And the valleys of death are particularly where we've not necessarily thought about that sort of pull through, that translation. And that's really one of the reasons why we're having the meeting this morning. Because if we can see the valley of death coming before we fall down it, then I think we'll be so much better prepared to say, where's our bridge? Where's our bridge to the next stage? And that includes working with all these groups that we've talked about. Next slide, please. But as many of you know, I talk about the translational circle, and I think multiple long-term conditions are really the best exemplar. So the circle means that you don't just go left to right and then stop, that you go left, you go around the circle from the discovery science into the clinical trials phase, through the phases, into implementation, into real world, and you stop and say, well, what's working and what's not? And it's that real world, that implementation into the real world, that tells us whether it's for the patients of today, that 14 million with multiple long-term conditions. And then you go, it's bidirectional. You go backwards and say, well, the earlier in this translational circle that you involve people with multiple long-term conditions, the more likely you are to understand those disease trajectories, those disease clusters that would enable us to have treatments that really do work. So patients in the real world are not often like that very tightly defined phase 2 trial group. Now, I work with plenty of people who work in the phase 2 trials space, and they tell me why it's important. But our own EMI program is really looking at how to encourage people to be more inclusive rather than more exclusive, so that we really think about that pull through sticking. And the clusters work is also going to be crucial to understanding those biological mechanisms and thinking about drug targets from a different perspective. So not just going down the disease pathways, but really thinking about, well, how does hypertension and diabetes interact? And where could we find drugs and interventions that worked in synergy for both of them? So by looking at it as a circle, that also pulls in where the policymakers are really relevant to to this, and saying, if we just involve policymakers in the top left stage into that real world and that implementation, what if we involve policymakers at understanding the upstream areas? And where does the sort of addressing health inequalities get woven in around the whole circle, so that, again, we're not surprised when an intervention doesn't work as well when you roll it out across the country, if we've not even included those representative groups in the earlier phases. So that inclusive approach, I think, is so crucial to making our research really land. Next slide, please. So we've talked about how the strategic framework really is aiming to address the evidence gaps that were named in the Academy of Medical Sciences report, to use the cluster approach to say, how can we take a scientific approach to understanding what these clusters look like, and the what next comes. So many of you might have seen the seismic call, which is to look at systems engineering. Why are we doing that? Because if we involve researchers from different communities to tackle a complex problem, we are much more likely to see solutions from different perspectives. And one of the themes of today should be listen to those different perspectives, listen to all voices. I saw students putting their names into the chat. What have they got? What are they going to, they're going to see something from a perspective that those of us who have been working in certain areas might not see. So listen to all the voices in the group today, and ask what are they seeing that I might not see. Next slide, please. So I mentioned that the seismic call, how can the groups on this call look at this and say, what could I do in this space? Where can you come together in collaborations that really start to sort of firm up the networks that you've heard about from Chris this morning, and looking at the development phase and then those innovation hubs? You are going to be part of the move to change multiple long-term conditions research and pulling through into policy. And this seismic call is part of that work. Next slide, please. So happy to take questions, but I'm going to throw a challenge out. What will you do differently after today's workshop? What will you take away that just shifts your thinking, and where this sandpit of people who are excited about these opportunities can do so much? Ask what your pathway to impact is. In days gone by, when I was a researcher, I thought it was something you did at the end. Now I think it's something that we should do at the beginning. And then where do we also pull in health inequalities at the beginning? If I look at my slides and that I give in other talks, the health deprivation is such a crucial driver. And if we can make it woven into all the work that we do on multiple long-term conditions, our impact will be so much greater. Thank you very much, Chris.
Lucy, thank you very much. That gives us a really great overview of the topic and where NIHR see things going. I think we've got time for perhaps just one or two questions. So if anyone wants to urgently ask a question, perhaps you could put it in the chat. See what happens. While people are just doing that, can I just ask Lucy, a lot of money has been invested in the first of those four priorities, the one about the clusters. Do you have a view about the other three?
So I think that we need to see funding going forward in a couple of ways. One is through dedicated funding, but the other is that we have to start socialising this across every bit of research. So we both need the special pathways, and we need people to ensure that this becomes part of normal research, as in it is not something special that only needs special calls. I can't speak for MRC and EPSRC and ESRC, but I want to think that all research funders are going to recognise the needs, and the research team headed up by Leanne and others on the call we are constantly looking in NIHR at how can we ensure that we've got the next stages and the pull through. I might have given a different answer before last Thursday, before the autumn statement, but I am more confident after last Thursday that there is a continued commitment, both from this government and any future government that might come our way in 2024, to saying this is a health and care need that is relevant. It's not going to go away. So we need to consider have that parallel track of dedicated funding and this community to go and be ambassadors for this being woven into everyday work as well. And I think there's place for both.
Great, thank you very much. Because one of the great things about those 4 aims is that the first one on clusters has engaged a whole group of researchers who probably weren't involved in MLTC research, but there's things for every other kind of social scientists who want to look about what's important to patients, to health services researchers like me who want to think, how do we change the way care is delivered? There are questions that will affect everybody, I suspect, here. I can't see any questions. I can see a question in the chat.
Kamlesh,
yeah.
Kamlesh, it's always nice to know that NIHR is ahead of the game compared to NIH. What another brilliant example. So that's a really interesting question, and I could take it a number of ways. We can collaborate with NIH, but we know that they will always have a bigger budget than us. That's how it works. So we can look at who should be our partners. And I think we've got a couple of interesting options. The first one is global health research. We have our own global health research program. And I'd like to ask this community to think about what can your impact be in partnering up. And I know there's already work in this area, but where do we support colleagues in global south, other areas in low and middle income countries, because I think we can have really huge positive influence in supporting researchers from those. And if I had to say, where do I think our impact would be greatest? Top of my list would be those in the global health community. The other area that we're looking at is international non-ODA funded work. So other high-income countries. And whilst I think NIH is always interesting, there are others. So we have an existing partnership with NHMRC in Australia. And for example, we're looking at partnering with the South African funders, where again, it's about our impact. So it's not that I think we're just the younger sibling to the NIH. I just think that this group of researchers should be proud of what we're doing in the UK and think about where to utilise your wider networks. Not excluding the Americans, but also particularly in the LMIC space. And Kamlesh, I don't know whether that addresses your question, but hopefully that LMIC piece I think is something we are so strong at.
Excellent, thank you. I'm sure there could be more questions, but we have to move on to keep this on time. So Lucy, thank you so much for your talk. Really nice to see you here. And I'm now going to hand over to Kamlesh Kunti, who's going to share the next part of the meeting. Kamlesh, thank you.
Chris, thank you very much for introductions, and Lucy for setting the scene. So this is a real quick question and answer session. We've got panel members who have been working in the area, particularly in terms of the implementation aspects of multiple long-term conditions. So we'll have 2 minutes from our panel members, and there'll be a quick fire question answer sessions. We've got about 30 minutes here. So first of all, Richard McManus. Richard, who is well known in the area of hypertension, but he's been working in the area of multiple long-term condition, has got an ARC funded study at the moment. So Richard, over to you.
Yeah, thanks, Kamlesh. As Kamlesh has said, I'm a GP and a research, particularly in prevention of cardiovascular disease. I guess that in my 2-minute soapbox, the thing I'd like us to think about is when we're doing research, firstly, that we don't throw the baby out with the bathwater. And historically, we've excluded people with multiple long-term conditions by design almost. I've been on a European guideline committee this morning and looking at the data in trials of people over 80, for example. Something like 2/3 of the people that we see in primary care get excluded from those trials. And I think that we should, as well as thinking about diversity in terms of protected characteristics, we should be thinking about diversity in terms of multiple long-term conditions. The second thing is that we saw during COVID that the routinely collected data in the UK is second to none internationally, and I think we should make more use of that. The study that I'm being funded on in the ARC core is about looking at structured medication reviews and intervention, for which that it seems an obvious thing to do, but there isn't actually very much evidence. We're studying it, but actually that when these things were set up, there could have been a whole set of indicators put in using routine data that could have done this. So I don't really want to get myself out of a job, but I think where we're implementing new interventions with less evidence, that should go alongside routine data to find out whether they're actually doing what we think they're doing.
Thanks very much, Richard. A little bit more than 2 minutes, but I'll let you off on that one. Next one, Chris. Chris already has been introduced. Chris has been doing some great work over the last 10 years, particularly in models of care. So Chris, over to you.
So as you said, I've been working in multiple long-term conditions for about 12 years and studied on epidemiology, the measurements, developing interventions, and probably the thing people might know is the 3D trial of a randomized controlled trial of an intervention a couple of years ago. And currently I'm trying to do an implementation study to try and understand what makes it so hard for practices to change the way they provide care, and how can we overcome some of those barriers. My kind of key message would be, we were asked to come up with one key message. I think it's naive of any of us as researchers to think that any one piece of research really makes a difference. Rarely does it make a difference in the real world. It's when policymakers hear the same message repeatedly from lots of different sources, and in particular when they hear it from patient groups. And that's why I think it's really key to work with things like the Richmond Group of Charities, who've got an emphasis on this. So just trying to get the message across in multiple different ways so that it keeps on being heard. And I think then that's what leads to change.
Yeah, thank you, Chris. Now over to another good friend, Rohini Mathur. Rohini, over to you.
Thank you very much, Kamlesh. So hello, everyone. My name is Rohini, and I'm an epidemiologist based at Queen Mary University. I'm working on a multimorbidity project looking particularly at early onset multimorbidity in minority ethnic groups, and in particular differences by sex. And I think the work that we have done has really shown the importance of understanding that multimorbidity covers a range of conditions which are not necessarily common in the general population. So, for example, in our work, particularly among South Asians, female infertility and painful conditions come out as really key priorities. And so I think the key messages from our work are really about how to prioritize healthcare services and to target populations that may not fall under our traditional banner of multimorbidity, and understand that conditions which are more common in minority groups, or particularly sex-specific groups, may have a really high financial and healthcare impact. And so to keep these in mind when we're designing services and thinking about how to provide care equitably for different populations.
Thank you, Rohini. And our final panel member is Professor Sinead Brophy, Deputy Director at National Centre for Population Health and Wellbeing in Wales. Sinead, over to you.
Thank you. I'm the director of the National Centre, which brings together Public Health Wales and 3 universities. I'm also the early years lead in the Administrative Data Research Wales, which is a partnership with Welsh Government. And I'm a member of the Mum Predict, which looks at multimorbidity in pregnancy using routine data. So my key message in my experience is implementation is really about timing. So I think there are cycles when a policy or a service is being reviewed or updated, and that's when evidence is very much welcomed. So there are specific times when I feel there's an open door and people do want to know what evidence there is that can be used to inform change and what's about to happen. And that's when research really is welcomed. Outside these windows, quite often the latest evidence isn't seen to be that interesting or relevant to the cycle that's going on at that moment in policy or decision making. So I think knowing the timing is really, really important if you want to make a difference to get your research listened to. So that's my view.
Thanks very much, Sinead. We've got 96 people on the panel here. I haven't seen one question as yet, so please, these are really great experts here who you can get lots of information. They've been working in the area of multiple long-term conditions for many, many years. So please do ask them questions. So I've got a question here from Jackie. What is the best way to achieve wider representation and capture patient voice and patient involvement in groups that are physically difficult to reach? Who would like to take that from the panel? Rohini, you're talking about the minority ethnic population. Maybe if you want to start first, and then others could have a think through.
Yeah, so I think talking about, identifying groups which are hard to reach, really is about kind of redesigning our services to ensure that they are included when we are, targeting and designing our services. And so, East London, we're very lucky. We've got a really strong network of community engagement, partially through the Genes and Health study. And so, we really involve people in understanding about the research that they're contributing to, feeding back regularly to our participants who contribute not only to the cohort studies, but also to the electronic health record data, which we are using to do all of our multimorbidity research. And so it's really, I think, about keeping people on side, engaging them throughout, and making sure that their contributions are valued and they don't just go into the ether.
Any other panel members to discuss about representation of the population? Richard, please do go ahead.
Yeah, happy to talk about this. We're doing some work in pregnancy at the moment, and really trying to target people who are harder to reach in that context. And I think a lot of it is just opening your eyes at the beginning and not just going for the low-hanging fruit, which in any kind of research often tends to be white, middle-class, middle-aged people who perhaps aren't working. And there are plenty of patient participation groups that one can engage with to start with, but also actually just making it clear that you are going out and asking for people's views can make a huge difference. I think sometimes you have to, particularly, I think the question referred to people who are with carers and so on. Many practices have carers registers. It is possible to find people via their carers. I think taking it out of the too hard to do box is probably the thing, and putting resource in the study that I was referring to in pregnancy. We put a whole work stream about diversity and difficult to reach groups. So you have to actually put your money where your mouth is. And I think funders seem to be happy to take that on board.
Yeah. I think you're absolutely right, Richard. We've been working in diverse populations for many years, and the only way we get representation is using different methods to recruit these. It's no use our usual methods of going through primary care practices and sending them letters. You need to work through all the community organizations. We have a number of community champions that we employ ourselves to recruit the population of Leicester, which is, as you know, 50% from minority ethnic background and deprived populations. Okay, we've got some more questions here. So there's one here regarding, this is a really important question. Should we be talking about the number of multiple long-term conditions, or should we really be talking about specific clusters of conditions? This is from Ali.
Can I respond to that, Kamlesh?
Yes, please do, Chris.
I think it depends on what kind of research you're trying to do. Those of us who are into this world talk about the distinction between comorbidity research, which is diabetes plus other things, or hypertension plus other things, versus multimorbidity research, which is a more generic term. I think there certainly are questions that comorbidity research about specific diseases needs to be answered, but in a way there's been lots of that. And I think what's more difficult and what really challenges me is a more generic research about changing the way in which we provide healthcare for people with multiple unspecified diseases. So if you're in primary care, I just don't think the future is designing services for a specific clinic for people who've got lupus and arthritis and diabetes, and a different clinic for people who've got hypertension plus asthma plus heart failure. We need a model that applies to the fact that most people using healthcare have got multiple conditions, irrespective of what those conditions are. And I suppose that's the challenge that excites me, but it isn't to say that there aren't good questions about specific diseases, of course.
Okay. Any other panel members want to come in? Richard, I think maybe frozen. Well, he's frozen to me anyway.
Still here.
All right. Okay. Any points from panel members? Otherwise, we'll move on. No. Okay. I think Sinead, next question was directly to you. You can read the question. advice you'd give us on how we can keep ahead of the health and social care policy across the 4 nations?
Well, in my view, working as researchers, so working across the 4 nations really with local people, so not trying to run things from one place, but actually working across with other researchers so that everybody is aware of what's so that there is somebody in each place can be aware of what's happening in their area or in their nation really. And so I think not working in silos basically, but actually working with others, very much multidisciplinary, and working with people in different nations helps you stay ahead, or helps you. And I think it is local contacts that make the difference to knowing what the good questions are to even start looking at and being able to work with local people so that you can have impact, because obviously people only want to bring in things that they feel are important and relevant from the beginning. So that would be my quick answer.
Great. Thanks very much, Sinead. This is another really great question from Shukrat, and many of you I know using patient-reported outcome measures. So how widely used and how useful are patient-reported outcomes for multiple long-term conditions in clinical practice? Chris, you've used them in your 3D study and others as well.
So I think they are really important, because I think some of the outcomes that really matter can only be detected by patient-reported outcomes. So things like people's well-being and their quality of life, which are generic measures of what we're trying to achieve, I can't see how you can get those things except through patient-reported outcomes. On the other hand, I don't think they're widely used at all. In my current research, implementation research, I'm trying to introduce them as a kind of routine part of care to shape care, and it's difficult. It's administratively difficult. There's no point doing them in a kind of lip service way, as many people do with things like the friends and family tests, where they get a highly selected group of small number of people replying. You've got to get it from most people. It's got to be really embedded in your routines, and I don't think that's really working, at least not in primary care at the moment. I don't know how well it works in hospitals.
Okay, thank you. Anyone else want to come in at all?
Well, I was just going to say, along the lines of what Chris has just said, I think these aren't widely used. I think that they, particularly in multiple long-term conditions, that they may have some really interesting places. There's, for example, a developing literature about restricted activity as a sort of holistic measure. Just something simple like have you gone to bed for more than half a day in the last week? And that appears to be quite a useful measure in both predicting future mortality and potentially hospitalization. And so these sorts of measures, I think, definitely bear further study and may allow us to detect, for example, deterioration in a global sense in someone who's got multiple long-term conditions, or the people who are really at the extremes of that with lots and lots of different things, where getting them to try and monitor things individually is just impossible.
I completely agree with you, Richard. I mean, in terms of frameworks for what patients with multiple long-term conditions prioritize, there's 2 or 3 of those, and the 2 things that they care about is one is mortality, and the other one is quality of life. And similarly, using simple measures like that in clinical practice, as you mentioned, Richard, would be useful. The other one we have used haphazardly, I'd say, is how fast can you walk? Slow, medium pace, slow pace, or fast pace. And that's been shown to impact on outcome. And a really simple question, that's a lot of the data from that is from the biobank. Anyone else want to come in at all on patient-reported outcomes? No. So Tim, Tim's got a question here. Do panel have opinions on safe data environments being set up and how mature they are will be over the next few years in order to facilitate research with routine EHRs?
I can say a bit about that because of
Please, Sinead, please do.
I know NIHR UK, where Tim is also part of, is working very much on trying to make it easier and making data fair, so people being able to find it and use it and access it. I think there's I think it's really good that's a work in progress, if you know what I mean. But I think at the minute, it's still extremely hard to work across different trusted research environments. They all have different requirements. Most of them cost. And so it is quite a long and difficult process to access data from different places. COVID changes brought in due to COVID made that quicker and easier during COVID. But I think some of the gains on that may be being slightly lost now. And it's again becoming quite hard to work across different trusted research environments, quite long, time consuming and expensive. But I think there is a lot of work being done to try to change that. And I think NIHR UK are doing that, would be my opinion.
Anyone else?
Yeah, I can.
Please go ahead, Rohini.
I just want to say, yeah, I completely agree with Sinead. And I think, we're not maybe at the stage where they are completely mature, but we've got some really good examples of good practice through HDR UK and platforms like Open Safely, which are not yet being used for non-COVID research, but have shown the proof of principle that actually, if you set up an environment where people, have access to all the tools, you don't need to have the raw, potentially identifiable data locally to actually produce high quality policy relevant research. So I think inevitably it's the way of the future. And I think it'll be coming soon. Working across the TREs will be the next big challenge.
Okay, in view of time, we'll move on. We've got a few questions. In terms of the data environments, I think we are in a great position, as Richard initially mentioned. I know Jonathan will be talking about some excellent work they've been doing on the NHSE environment. We're already doing pragmatic trials at practice level in multiple long-term condition, either intensification or medications or de-intensification. So I think we're in a really good position, but we could, I'm sure, improve. Question from Amrit. What is the scope for estimating the health and economic burden of multiple long-term conditions and estimating cost savings for interventions? Very broad question. Any modelers here? No, I personally don't think we're there yet, because we haven't got that many interventions that have been shown to improve outcomes. Once you've got that, that's when you can do the long-term economic modeling. I don't know if you agree on that. Yeah.
Well, you can certainly collect costs at the moment in terms of resource use and prescriptions and the resources that from a wider societal point of view, in terms of the resources that families may be having to expend in terms of caring and so on. But I agree with you that the effectiveness side of it is a work in progress.
But I agree with the implication in the question that there probably is scope for more work on estimating the health and economic burden, so that if we do have effective interventions, we can see that it's worth investing in developing these, because the burden, I'm sure, is very high, and even slightly effective interventions could still save a lot of money.
Okay, next question, I think, Chris, directly to you, and then we'll move on in terms of providing more holistic care in clinical practice.
Yeah. I think this is asking about hospitals. I think the problem is the same in hospitals and in primary care, which is that we increasingly design all our systems around single diseases, and what people need is somebody who takes overall responsibility for them and treats them as a whole person. And I think that's a bigger issue in hospitals, where I would suspect that what treatment you get when you've got multiple conditions is largely predicated on which specialty you happen to get admitted under. And I think that, and I don't know if I should give opinions about how hospitals should organise themselves, but I think there needs to be somebody who can take a whole person perspective and who can coordinate the role of all the other specialists involved. And it seems to me, as an observer from the outside, that that's lacking in hospitals as it is in primary care sometimes.
Thank you.
I think that's a good rationale for more clinical academics in geriatrics or gerontology, because those are the people who've got a broad view from a medical side.
Question from Jessica. Can the panel share thoughts on pros and cons of focusing efforts on local service improvement versus research in this field? And I know some of you are involved, particularly through the ARC, through local service improvements. Anything you can add to that?
Yes, I can start.
Yeah,
so I think, particularly in the work that I do, and I'm sure it's true for everyone here, is that quality improvement and research are two sides of the same coin, and you need one to inform the other. So there's always a continuous cycle of back and forth and continuous quality improvement, which relies on the evidence that we get through our research. And with the MLTC research that we've been doing, we've been using data from across the country. So the findings that we have are relevant both to the whole population, but it can also be tailored to our East London population, because we've looked at, differences by ethnic groups, as I've mentioned. So I think there isn't necessarily a tension between these two aspects, and they both are really important and rely on each other.
I would.
Okay. Please do, Sinead.
I would suggest that it shouldn't be a divided this or that, but actually the two do need to work closer together on what are the right questions and what are the right ways of getting the answers to those questions. And so that it isn't research comes up with things that it doesn't help local service improvement, and then they can't get their research implemented, but actually these are one thing of the two working together.
Okay. I think we will stop there in view of time. We need to move on to the next session. Becky, your question is about policymakers. I think we should be able to take that in the next session, which is about influencing policymakers. So I'd like to thank all our panel members, first of all, for your quick presentations and taking lots and lots of questions. I hope you all find them useful. There are still some questions coming in. Maybe if people are aware, do answer these questions in the chat, please. Thank you. Over to you, Chris.
Thank you. Back to me. I'm changing role back to chair again, and it's my pleasure to introduce. We've had one panel from researchers, and now we want to hear from some policymakers, and I want to hear your questions for those policymakers. In the interest of time, I'll let them introduce themselves rather than me tell you all about them. But we've got 4 excellent people from different fields and different parts of the UK. So I wonder if I could ask them each to spend up to 2 minutes introducing themselves and sharing one key message or piece of advice that they want to give to attendees. Jonathan Vallabhji.
Yes, hi everybody. I'm Jonathan Vallabhji, National Clinical Director for Diabetes and Obesity at NHS England for almost a decade now. I'm a diabetologist by trade. My clinical and academic base is Imperial in West London. Over the 10 years, I suppose I've been privileged to have the opportunity to implement a number of work streams in the diabetes and obesity space. I think we've got 14 in total. And I suppose the principle of approach has been, firstly, and I guess that's most relevant to today's discussion, is to identify high quality evidence that can be translated effectively at health system population level, number one. Number two is then to make the case, and this is my role then, make the case for funding within the health system. And very much to back up Sinead's earlier point, that those funding opportunities are not continuous, they're episodic. And that's a really important point to understand. And the cardinal opportunities come with a government comprehensive spending review that usually follows a general election. So the next one is likely to be in around 2 years' time. So having then successfully made the case for funding, we've looked at implementation within the live environments of the NHS at scale. And then the fourth point is to always evaluate, and we're very fortunate, as has already been mentioned, so evaluation using real world data is the real opportunity we have here in England. So that is the cycle. An example would be, I suppose, the first and largest undertaking was the NHS Diabetes Prevention Programme, launched in 2016, achieved universal coverage of the population of England by summer of 2018. We've had over 1.1 million people referred in, and the latest evaluation using real-world data shows that it does what's written on the tin, reduces incidence in participants, but also using sort of difference in difference approach, exploiting the phased rollout of the programme, seems to have a modest impact to reduce incidence at population level as well. So those are the principles, I think, of policy implementation. I think that's why I'm here today. Kamlesh did allude to some work we're doing. We exploited the power of national data set linkage during COVID, which is huge and led to us being able to answer some of the sort of important early questions in the pandemic. But we're using the same linked data sets now for a piece of work around multiple long-term conditions, which is what Kamlesh was alluding to earlier. I think you're on mute, Chris.
Yes, and I did it first. Lorna Kelly, please introduce yourself.
Thanks, Chris. I'm Lorna Kelly. I'm the National Strategic Lead for Primary Care at Health and Social Care Scotland. So that's the network of all the integration partnerships in Scotland. And I work closely with Scottish Government and currently chair their Primary Care Health Inequalities Development Group. So clearly a different policy landscape in Scotland, but really important to be able to operate across different policy contexts, both within the UK and further afield. So I've got a bit of a background on both sides of this debate, so both in policy and strategy, but also previously heading up a research programme and leading an impact model. But really I've spent most of my time in the grey area in the middle, where having clear access to evidence and research really helps me to influence policy effectively. When I worked at Glasgow Centre for Population Health, we were challenged once by a community organisation who said, well, why are you researchers also obsessed with bloody policymakers? What about real people? So I want to pass that challenge on to you this morning and prompt you to be thinking about who's really your audience. So it's not just a single policymaker in a darkened room somewhere, but what's that widest group of those who are helping to shape policy and practice? And how can you make it easy for that broad audience to find, use and implement your findings? And to start with, are your questions and your lines of inquiry grounded in an understanding of real world problems and priorities? Thank you.
Thank you, Lorna. Then Jacqueline Bouvie, thank you.
Thanks very much. So I am Jacqueline Bouvie. I am the Technical Director for NICE Scientific Advice. And what I want to highlight is a couple of ways in which NICE and researchers and other organizations who are developing research or developing evidence that might be looked at by NICE at some point can actually engage with us to ensure that the evidence that is being generated and that research that is being conducted can actually be considered by NICE, hopefully downstream. And there are two main ways in which we do that. So the first thing that I would like to highlight, especially for researchers who might be developing either clinical studies or methodological research or new methods in taking better account of multimorbidity and multiple long-term conditions. NICE has a science policy and research program, and that program offers different ways in which researchers can engage and get input from NICE in different stages of the research. So we either take consideration of research that has been conducted, but in the early stages of developing your research, NICE can offer different ways in which that research can be supported. So one thing that we do is that we can offer letters of support for grant proposals that are addressing important research recommendations that have been made by NICE in the past, or research that might align with some of NICE's research priorities. And I think we can put a link in the chat to the landing page where you can find more information about that. But I did want to highlight that NICE actually has a clinical guideline on multimorbidity, and that one was published in 2016, so it might not be terribly up to date anymore. But there are a number of recommendations for research that were made by that guideline committee, which usually identifies important evidence gaps for that particular clinical guideline. So if anyone is developing research or is planning to do research that might address or might close some of those evidence gaps, that is an area where NICE would be particularly interested, and getting in touch with our science policy and research team, I would definitely encourage you to do that to make sure that we can give consideration to that research. And then finally, the team that I lead within NICE is the scientific advice team, and we offer advice services to any organization or company that might be developing evidence that might be evaluated by NICE at some point. And although that primarily focuses advising pharmaceutical companies or developing clinical studies, that is not limited just to that group of stakeholders. So if you are developing more large-scale clinical studies, that is something that you can also get in touch with us in that way and see how we might be able to support your clinical studies. I'll leave it there. Thanks.
Thank you very much. Callum Higgins.
Hi, yeah, I'm Callum Higgins. I'm the Public Affairs and Policy Manager at the Chartered Society of Physiotherapy in Wales. I'm not a clinician by background. I've worked for politicians and third sector organisations in the past. And I had a legal background before that. I moved into public affairs by accident when really seeing people come to the pipeline as citizens' advice, where I was, and finding that health issues were what were triggering their problems at the end of the day. Looking at the source of their problems, it was health issues in the main, physical or mental. And I wanted to have an impact on that and really try and help them at the other end of the pipeline and influence decision makers in the health sphere. So my message today is to look at influencing a bit differently. I like to say it's the art of storytelling about your work, and take a step back and think, as Lorna said, about your audience. And really, most people, we forget, are human, and they'll listen to a good story. They'll listen to a story with a hero, I like to say. There's a bit of a story arc to it, and you ask them to take action to help you in that story. That's the key thing. You want to make them buy into what you're trying to solve. So if you just take a second to think about your work, I imagine most of you are very academic in the way you work. You have lots of evidence to back things up. But what gets somebody to read it? That's the key question. What gets somebody to sit down and think, that evidence, I want to read that. I want to see the methodology behind their point. And that's what the story gets you. Is that story gets you to somebody to sit down, somebody who's not got much time, is trying to make lots of decisions, is looking at budgets, looking at rational things. You get the emotional buy-in if you can present a story behind your work and why you're doing what you're doing. And that's really my advice, is right at the beginning of your work, of your research, think about why you're doing it and package it in that way, slightly differently depending on the audience you're talking to, but particularly at a political level. If you want that buy-in, you really need to think about why you're doing it, what the problem is, what's the villain in your story, what's bad and what needs fixing, and how can they help you achieve what you want to do as a researcher and get your point across. So it's taking that step back is my point, and really think about why you're presenting to the person you want to influence right from the beginning. Thanks, Chris.
Thank you very much. So we've got 4 people with a lot of experience, but from very different kinds of backgrounds. So they're really well placed to answer your questions. So can I encourage you to put lots of questions in the chat, and we'll select from them. Just to get started, I want to pick up one from Jessica Catchpole, who got in there really quickly with a really excellent question. She says question for Jonathan, but I think it relates to what Lorna said as well. How can we better use the voices of people living with MLTCs as advocates in a way that policymakers actually take notice? Worked for many years at Diabetes UK, mobilising people with diabetes, and one of their frustrations is they put in a lot of emotional work and don't feel listened to. So Lorna said policymakers say we want to hear what about the real people, not, they're the people, and yet the people say nobody pays any attention when we express our view. I'll start with Jonathan because it was addressed to him. Any thoughts? Yeah,
Thanks, Jessica. And I know that you're affiliated with Diabetes UK. I mean, I think it is the role of policymakers to take account of what people want, as well as what research is being produced out there. Of course, nowadays, research, there's a very clear requirement that the views of people affected by the sort of area of research have inputted right from the start, which is an advantage. But I think it's really important. I alluded to in my little sort of 2-minute intro that part of the first stage in the cycle was to identify high quality research. And what makes something identifiable and useful is a major pull is that people want it. And to take an example that you'll be familiar with, Jessica, because Diabetes UK funded the direct trial, which was about achieving remission of type 2 diabetes, you know, the very clear enthusiasm with which that was received by the diabetes community more broadly, including, you know, obviously people living with diabetes, what I'm referring to, was so obvious and loud that made it a much easier choice to run with that piece of policy. I mean, I've got, so I think that's a really important component and answers, I hope, Jessica's question to some point. We've been working on this multimorbidity theme within NHS England for about around 15 months now. Personally, I think it's fair to say that we found it much more challenging to engage with people of relevance with lived experience, because, and this goes right back to the beginning, the intro that you gave, Chris, everything is geared towards single conditions. We often, in my line of policy, we engage with Diabetes UK to support us to glean the views of people with lived experience. But when you look to do that for multimorbidity, multiple long-term conditions, it's a very immature field, and it's not quite so easy to knock on the door of a third sector organisation, let's say, to support us to do that. We have the NIHR actually to support us with that. But it's quite challenging, I would say, at the moment. And I think many of the people on the call may have more insight into that in terms of launching their research than many of us on the panel, actually.
Thank you. Lorna, do you want to add anything? Can I just say to all of the panel, can we try and keep our answers short so that I get a chance to ask some more questions as far as you can? But Lorna.
Yeah, I think it's a real challenge back to policymakers, because I think we can be very greedy about how we use lived experience and patient input, and suck a lot of information out of people and not give an awful lot back. So I think there is a challenge around how you show that things are being listened to and what the outcome of that is, because it may be a long time before something gets from policy to practice that changes what happens when they go to their GP or go to other services. So I think pushing for that kind of response and being able to show how that works. If I can give an example, we've been working on a national inequalities group with a community organisation. They've done a very specific piece of work looking at digital inclusion, and we've been able then to show back to them where that's gone, who it's been sent to, where the report is, and they appear at other sessions and see that their work has had an impact. Now, day to day, it doesn't make a huge amount of difference to them, but it does at least make them feel as if they've been heard. So I think that's a really fair challenge. And there's something around trying to shape that lived experience input to be answering a specific question or part of a particular project that's got an outcome, because otherwise I think you're right, it can all be absorbed and listened to, but perhaps not get very far.
Thank you. Let's move on to a different question, one for Callum. Very helpful advice about storytelling and villains. What would be your advice for grabbing policymakers' attention in the first place?
Yeah, thanks for that. I'd say that the biggest thing is having a collective voice. So speaking from experience in the rehab space in Wales, during COVID, we grabbed sort of policymakers' attention by collectively as professions, the AHPs in particular, together, and third sector charities representing patients. That collective voice had a huge impact. We were able to go to the government with a package of recommendations and things that we wanted to put in place collectively. We were telling what the problem was and how we wanted to fix it at the same time. And that was an easy grab for policymakers to go, brilliant, thanks. Like we were wondering who to ask, but you've come to us. So it's making that easy approach, having done the hard work for them. If you can get that work done, the stakeholder engagement beforehand, you're a step ahead and you make life a lot easier for the policymaker in that sense. And I think that gets you the initial buy-in and trust if you go in the approach to influence something straight away.
Excellent. Does anyone want to add anything to that question? Please keep your questions coming in the chat. Jonathan?
Yeah, maybe if I could just state a truism from a policy perspective. I can see the sort of framing of the questions is, if only those policymakers with deaf ears would listen to us, and if only we could get their attention, we'd be able to translate our research. I think a really important consideration is the research translatable? And dare I say, much isn't. And I think it's really important from the outset to consider the translatability of what you're doing. And really important factors are, number one, affordability. I've talked about funding opportunities, but it has to be a reasonable cost envelope to make the bid for funding, number one. Number two is the delivery in live environments in the real world. And of course, the biggest challenge for our health system and many health systems globally is workforce. And so you need to be mindful of what the additional ask of workforce would be to be able to translate your research findings into routine practice. And if the ask is huge and huge additional man hours of workforce in time investment, it's probably just not doable. And so I think considerations of that up front are really important.
Thank you. Another question, just follow through on the stories a bit more as well. I kind of feel we sometimes talk as if decisions are all based on scientific evidence, and researchers often think that means randomized controlled trials. And yet policymakers often say, but there isn't one that's exactly in my scenario, in my setting, or that's translatable because it's a different context. And I think that decisions partly get made in a rational way, but often get made a lot through conversations, through networks, through people who know people, through people who trust other people who've said things before. And often there isn't a perfect answer that's in the evidence. They have to make sensible decisions with uncertain information. And that's true of probably all big policy decisions. There isn't one randomized controlled trial that tells you what to do. You're doing things that seem sensible, that have got some sort of basis in it, they're consistent with the evidence, even if there isn't absolute evidence to say that it's the right thing to do. And policymakers sometimes just have to make decisions of things that are sensible and affordable. And often they'll listen to people that they trust because they've known them for a while and they've, it's networks and contacts. So it's having those stories alongside, but making sure that as scientists, that our stories are true. They're based in the evidence. They're not just stories. And keep some questions coming in the chat. I can't see anyone anymore at the moment. Sophie, is there anything I've missed?
No, nothing coming through at the moment.
Okay, in which case, can I ask those of you who are having to make decisions based on evidence, where do you look? How do you find your evidence? Where do you look? What kinds of evidence do you find helpful or unhelpful? Perhaps I'll ask, I think I can guess Jacqueline's answer, but I'll let her start.
Thanks. I think I'm sure many people will be familiar that NICE has well-established methods for how we identify and then assess and appraise evidence, and it depends a bit on what part of NICE we'd be looking at. So often we rely on systematic literature research as published evidence, but depending on different types of programs within NICE, it might be unpublished evidence that is submitted to us by pharmaceutical companies. Or real-world evidence. It really depends on what the actual decision problem is that NICE would be looking at, and that differs in different functions that NICE has. But I would echo, I think, what Jonathan was saying earlier, and what you were saying, Chris, as well, is that NICE as well, even when there are RCTs available, those have their inherent limitations as well, as that they often have, and I think that's very relevant in this particular setting, that they have great internal validity, but their transferability to the actual population in the NHS is not always great. And that is why NICE also relies on independent committee, because the evidence is one input into that, but if there is very scarce evidence, or the quality of the evidence is not very good, NICE still has to make recommendations. And I think that is an important area to highlight, that the evidence does not always tell us usually does not tell us everything, and a recommendation still needs to be made, which is also why NICE has a keen interest in helping the field and helping researchers to make sure that the quality of the evidence that we see and that addresses the questions that NICE committees need answering.
Thank you. Other members of the panel, Lorna.
Yes, I was thinking about not so much how I make decisions, but if I'm trying to influence a wider piece of policy or have an opportunity to be talking about multimorbidity, where do I gather evidence and how do I do that really quickly? Because I just don't have time to stay on top of absolutely everything. And some of that's relationships. So I know there's a couple of people in universities in Glasgow and Edinburgh that I can pick up the phone to or drop an email to and say, what's going on around this at the moment? What do I need to know? I will spend half an hour on Google. So you need to make sure that whatever you do is visible and comes up clearly, either as research or because it influences other things. And I'll often look to organisations like the Nuffield Trust, like the King's Fund, like the Health Foundation, who are just really good at being able to present things in a way that's relevant to context. And so really basic things, infographics, use of presentations. I saw a presentation last week on some research that had been done in the University of Glasgow that I'd read before. I read it about a year ago, but the way it was presented very, very clearly made a couple of things stick in my mind that I can think of where I can play those into a national piece of work around access. Think about that presentation and how easy you're making it for people to find. Thanks.
That again fits with the stories idea that, you've got to have an elevator pitch at the key point, like you got from the infographic. Jonathan.
Yeah, I mean, the most important source of high quality evidence to consider for implementation is the peer-reviewed literature, and within one's field, one has to do one's best to be up with that from a policy perspective. Also, in terms of your point, Chris, really good point that sometimes there won't be an ideal randomized control trial that fits what you're after. It doesn't stop at the end of the randomized control trial. And I've mentioned implementation science with wrapped around evaluation using real world data. We are incredibly fortunate in the UK to have such richness of real world data. Every data point in health is captured electronically. Certainly in general practice, we're a bit slower in hospitals, but catching up. The second dimension is that it's nice to think that policymakers can sit there and choose the best evidence and implement evidence-based policy. It's not always like that. Sometimes there will be someone very powerful in government who wants something done in some area where there is a lack of evidence. And that can be a much less comfortable position for someone, for a policymaker, certainly from our perspective. And I could quote some examples of that where there has been an absolute imperative to run with something with lack of evidence. But again, one does one's best to go with as good as evidence there is, implement and evaluate, but be very clear. And that's what we call a pilot. And some people say that the NHS has, what's the term, more pilots than NATO. But, you pilot something and evaluate with the very clear deal that if the evaluation is panning out well, okay, scale up. But if it's not, then you park it.
But those very important people get their ideas from somewhere, something they want done. And I think, well, where do they get that idea from? And I'm guessing that it's partly, again, what I was saying about networks, it's partly about pressure groups, it's noise in the newspapers. So in a way, I think it is up to us to generate the right kind of noise, working with patient groups, for example. When enough people are saying something needs to be done about, I don't know, waiting lists, then very important people will say something's got to be done. Somebody asked the question, as well as the people on the call, how do we best search for policy contacts? That's a very good question. And as a researcher, sometimes I want to engage with policy, but I don't quite know how to find the right people to engage with. Any thoughts?
I'll just jump in there. That's what I do for my members. So professional bodies will have people who have these connections for you. If you are a member of a professional body, I would bite a hand off my member who approached me and said, I want to speak to policymakers, because I'm always trying to encourage them. And it's actually quite difficult sometimes to get people to do it. Maybe they're maybe just a bit shy, or they haven't got the confidence. They're thinking they're going into a very strange world in terms of policymaking and politics and that sort of thing. But there'll be people out there in professional bodies or network chairs and people like that out there who really would like engagement with people who are interested in influencing policymakers. So it's a matter of putting yourself forward to these people if you can find them, and make those personal contacts and relationships. And then you'll find that once you do it a couple of times, the doors open. and more people will know your name and will approach you. So there's no easy way of doing it. It's about networking really, and using every opportunity you can to highlight your work in any stakeholder event or anything like that comes up. Just get out there and sell what you do with some confidence.
Great, absolutely. Any other thoughts? Can anyone give an example of something that researchers have done to engage with them that they found? Lorna's given one example already, the infographic, but has anyone got the other examples of things that they found really helpful that researchers did to help get their message across? No.
Well, it's obviously useful for researchers to engage as early as possible in the process with policymakers. I'm very happy to be approached in my neck of the woods early on. The NIHR in particular, and most grant awarding bodies, are actively encouraging that from very early stages. And I've very much noticed an increased flux into my inbox of approaches from people very early on. And I suppose there needs to be a balance of how much time one can invest getting one's brain around multiple projects at the pre-submission phase of the first call, balancing that with projects that are more likely to get funded. And so there's an issue of how you best deploy your time. But I think trying to get your objectives and your projects on the radar of policymakers, or at least bounce the ideas off them as early as possible, I think is a really sensible ploy if people can do that.
So in a way, you're creating the appetite for people who want to know what the answer is going to be because they've known about the studies. Yeah. Lorna.
I think the best things from my point of view are things that put the research into context. And that's partly the implementation context, but also partly just the wider service and social context of what we do. Because very often research will be very specific; it might be quite narrow, but it adds to lots of it adds to the field of knowledge. So I think as researchers, it's really important and incredibly valuable if you understand your field, not just your research. So you're able to really clearly say what this adds, what everybody else is saying, and then what it might mean for practice, because it starts to put it in a kind of language that I can do something with.
That's helpful. Thank you. I see there's another question from Simon Fraser, but I'm afraid, Simon, we've run out of time really to answer it. But if anyone would like to answer that in the chat, please feel free. But I'm keen that we stay on time because you now have a 10-minute break. Please go and quickly make yourself a cup of coffee or whatever. I suggest you leave your Zooms on and then we'll start up again at 11:30. Sophie, I think you wanted to quickly do a quick poll again.
Yeah, just before people leave, it's going to pop up. It should be on your screen now. This is just to, again, help us understand how useful the event has been.
Yeah. Also, while you are doing poll and taking break, I would just like to request everyone to please consider if there is anything more that funders can do to support your knowledge and understanding on engagement with policymakers on MLTC research. Please pop up any suggestions or feedback in the chat or after the event. We're very welcome you to write any notes or thoughts to the multimorbidity email address. Thank you.
Okay. Thank you. So everyone, feel free to go, but be ready to start again at 11:30. I want to make sure you finish on time, so we'll try and start again on time. 11:30. See you soon. Welcome back, everyone. We're ready to start again, and in a moment we're going to put you into breakout rooms where you're going to have 25 minutes to discuss and agree on. Your task is to identify 3 facilitators to achieving implementation in MLTC research and 1 barrier. Make sure we focus on the positive. So 3 facilitators, but just 1 barrier. Could you nominate 1 person from your breakout room to briefly feedback? I'm not quite sure yet how many groups they're going to be, but be prepared to give a very short feedback on what your 3 facilitators and 1 barrier were. We'll be coming back, ending the breakout rooms at 11:55. So you'll probably find it just suddenly stops and you get put back into the main venue. So be prepared for that and be ready to go. I hope that's all clear. So I'm hoping everybody is back from their breakout rooms. We've now got 20 minutes to just hear what you all said. We've got 8 breakout rooms, so that gives you about 2 minutes per group. So try and keep your comments brief, and maybe if what you were going to say somebody else has already said, you can either say something else or just have 2 facilitators or 1 barrier. Let's try and think of the positives, the positive facilitators. So let's, I don't know if they've got numbers or something. How am I going to introduce the breakout rooms? While you're working that out, I will start with the group I was in, where Alice Harper is going to tell us what people said. So Alice, do you want to start?
Yeah, perfect. So I think the first thing we talked about, which is relevant to today, is thinking about the kind of events that you have within the multimorbidity sphere, and good networks, and working with different people across lots of different disciplines to, I guess, from a sort of junior researcher perspective, know sort of who you can approach to help facilitate implementation of research. The other thing we talked about was working with other organisations. So particularly within a kind of IT sphere, if we're doing sort of trying to implement things within clinical practice, it's about working with other organisations to provide the appropriate tools and resources, which can then be used, hopefully, sort of nationally for other people to implement elsewhere as well. We talked about the availability of data as well, so increasing recognition of trying to link up data that's available from different areas, so particularly between primary care and secondary care. So that was sort of 3 quite quick facilitators there. Barriers we talked about were healthcare professionals in different pockets, maybe not having academic backgrounds. So we had a dentist within our group, and she in particular was talking about how there's barriers to sort of pathways for academic training within dentistry, and then it's about getting sort of different voices across the MDT involved in research for those with multiple conditions, because obviously everyone needs to be involved.
Brilliant, thank you. Thanks for keeping it brief, well done. So we were room 2, and now I'm on to room 1, which is the room that had Alex Dregan and Anna Freeman in. I don't know who's going to speak on behalf of that group.
Yeah, I am Chris. Hello, it's Emily Henderson. Hi, so it's a bit like playing bingo because you've crossed off a couple with group 2. So just in terms of facilitators, we talked about having adequate resources broadly in terms of expertise and skills and finances and time to try and facilitate things. And the major barrier really came under the umbrella of complexity at an individual level in terms of aspects like cognitive impairment and dementia, the sort of settings people are often in, like care homes, and then more structural aspects such as the way in which healthcare systems are structured, and people have mentioned kind of silo approaches to healthcare already in a nutshell.
Thank you. Then room 3, which is the room that had Carrie Coop, Amrit and Jonathan in. Someone like to speak on behalf of that group?
I think I got voted to feedback. So facilitators for implementation of MLTC research were, number 1, harnessing the voices and views of those with lived experience makes it more compelling, number 1. Number 2, we were fortunate to have Leah, who's a health economist, who suggested that effectively communicating the output of health economic analyses so that the outside world and policymakers can understand is an important facilitator. So that's on number 2. And number 3 was developing interventions for MLTC with those alongside those who will be responsible for delivering those interventions meaningfully. the three interventions, and we agreed on a major challenge is actually designing endpoints that are sufficiently sensitive to be able to show differences between intervention and control groups, where perhaps the Cochrane review in the past has highlighted that just using patient experience may be too blunt a tool to actually pick up those differences. How's that?
Excellent, thank you. You're all doing very well at keeping brief. So that was room 3. Room 4 is the room that had Kamlesh Kunti, Andrew Hutchings, Rosa Parisi in.
So I'm Andrew Hutchings. I'll be feeding back on room 4. So we've covered quite a bit already. I suspect we're getting to the stage of duplicating quite a bit. So we agreed on the databases. We agreed on some of the practical elements of making research doable, things like having the tools. And the third big one we came up with was about engaging communities. So mobilizing local communities, involving patients and the public in that, bringing in the lived experience. So that was our other key facilitator. On challenge, we went for complexity, but within that, then some have been mentioned already, but other questions are the range of different conditions that contribute to MLTC, the prioritization of research and how we prioritize what is most important, the range of research designs from qualitative to quantitative, genetics to very applied, and different health and care settings. And also the questions range from everything from prevention through to treatment and a whole range of other types of question that we'll be dealing with. That's it, thanks.
That's both a challenge and an opportunity, all those different questions. Yeah, thank you, Andrew. Room 5, that was the room with Anna Bailey, Gillian Yeo, Mon Fletcher and Nigel Harris.
Hi, it's Nigel, so I've been nominated. So in terms of facilitators, we felt that the environment is right. So in terms of really recognition of the scale and that we need to do something. The second is around the funding. So the funders understand that this is a challenging area and are making funding available, which obviously is a really big enabler. We talked a bit about working together, and one of the areas, or one of the big opportunities, is that some of the charities, the Richmond group of charities, are now working together. So for example, the Stroke Association, Diabetes UK, are all working together to bring the voice of the patient. So we're not getting this siloed thinking, which we think is also, which can be a barrier. And of course, the formation of the ICSs, although it's too early to tell, clearly that around commissioning and provision of care and health is a big opportunity. In terms of challenge, really it is around systems change. And I gave the example of the Swiss cheese model, where you get an incident and getting all the holes lined up. And the same is true of implementing positive change. It's around how can you get the holes all lined up in the different elements to implement that.
Excellent, thank you. Room 6 is Sal Segaby, Emma Broom, Jackie McRae.
Hi, I'm Jackie McRae. I've been nominated to feedback for my group. So for us, yeah, a lot of things have already come up, but we had a discussion around getting involved with ARC, your local ARC, and getting closer to decision makers early on, and embedding implementation science as well early on as part of your research. Again, we also talked about charities as facilitators, collaborating widely, and some of the barriers really are around funding for engaging patients for even research priority setting, so much earlier along the line, and co-design. But also we identified that sometimes those links with patients break down when particularly early career researchers are involved in short-term projects. So those links aren't maintained, and sometimes it breaks down the trust that you are trying to build up with minority groups. So yeah, I think that was the extra bits on top of what everyone else has said.
Lovely, thank you. Room 7, Sinead Brophy, Katila George, Mariam Assad.
One of the facilitators is events like this, which actually greatly improves networking and ideas and strategies. Another facilitator is that Pathways to Impact is now built into funding grants, so it is something people are assumed to think about and have ideas and strategies on. And also, like with the charities, that there is now a recognition that multimorbidity is part of even in the individual charities. So there's really good funding opportunities if framed correctly. The barrier, though, is it's very hard for early career researchers to break into this because it needs such a multidisciplinary and really very large approach to the research. And quite often the funding you can ask for at the end isn't enough for early career researchers. So you have to work with charities to lobby and make a difference to continue this, because early career researchers is really quite short term.
Okay, thank you. And then last but not least, from 8, which is Emma Healy, Marius Hall, Ratner, Sonpal.
So I did Molly's Hall. I don't think we got as far as nominating anyone, nor did we really write down 3 points. But just picking up on the similar discussions, we really came up with the thought that it was quite difficult for individual researchers to have good and meaningful PPI engagement with enough representation from the multimorbid community. And we kind of thought that actually the funders could help with establishing groups such as this, which kind of could have lots of PPI involvement and maybe feed into several projects, so that the PPI representatives themselves feel engaged on a number of different projects, and they might kind of align themselves to a particular area, but also so that they don't kind of lose interest when inevitably research takes a long time to kind of develop. If there's several projects going on, there might be more things to update them on a regular basis. That was kind of our main enabler for sort of future research growth in this area that's meaningful.
Excellent. Thank you. Any barriers that you wanted to highlight? No. Okay. Good. Thank you. Well, you've come up, I've just been writing down a list of about 15 different things that people have said, which is great. And I can see that Montpledge has put something in the chat to say that the commercial sector, both pharma and medtech, are also beginning to change strategies and look across diseases, and could be a powerful driver in the future. That's something we haven't talked a lot about, the commercial sector, but certainly NIHR will be very keen on us working with them. Thank you, everybody. I think we've come up with a fantastic list of things, and you've done really well to keep it positive and not just focus on the barriers. Many barriers are also facilitators, in the sense that these are the problems, but we can see ways of trying to overcome them. And if we overcome them, then they could be a real facilitator. So the example of the data sharing we were talking about, it's difficult to link up data sets, but lots of people are trying to do that. And when it's achieved, that becomes a facilitator to do really good research across primary and secondary care and healthcare and social care. Now, throughout this whole exercise, we've had Alex Kagan, who is an illustrator, taking notes and trying to kind of capture all this conversation within an illustration based on this discussion. I realise I'm about 5 minutes ahead of time, Alex, so I don't know whether you happen to do this very fast, whether I'm asking you to share too soon, but in which case, tell me and I'll try and think of a joke or something for 5 minutes. But tell me, how are you doing?
Yeah, I think Sophie might have some of the images I've sent through to her if she's around to share.
Thank you, Alex. I should have introduced you earlier.
Oh, no problem. Yeah, that's fascinating discussion. I also work at the Wellcome Trust, so it's been fascinating hearing about this topic.
Just showing the first illustration, which was based on Lucy Chappell's talk, which Alex has produced.
Lucy's going to love this.
It's very accurate, isn't it?
Alice, do you want to say anything about your illustrations?
Oh, no, just I'm trying to, I think as was touched on in the discussions, I think infographics can be a very useful way of kind of summarizing and communicating scientific research and policy. So hopefully those will help contribute and kind of give examples of how those can be used in this kind of field.
Yeah, absolutely. We think visually, don't we?
Exactly.
I will just stop sharing and then share the second illustration that Alex has shared with us. We will be distributing these after the event as well.
I'd get the permission from Lucy first before
Hopefully that's popped up on screen. This is the second illustration. Give you a little bit of time to have a look at it.
I was going to say, these are going to take time to think about and take in, aren't they?
Mm-hmm.
They do capture many of the things people have been saying. And I hope people will take these away and think about, it'll remind them of some of the things we've talked about rather more quickly than watching the whole YouTube video. You know, I hope this will challenge some of us to think differently, or all of us to think differently about how we do research and how we translate it and how we make it available.
Can someone tweet these? These are fantastic, really good.
So yeah, so somebody saying, Morris is saying, wow, we've been dreaming of something like this, but difficult to find the connections. Can we use these things? What's the kind of...
Yeah, please, or at least from my side, people are welcome to use them however they want. That's the idea of making them, is for them to be spread around and used constructively. So please, anyone feel free to use them in talks or presentations or share on social media, whatever you think would be best.
Excellent, thank you. So Sophie, will you make these available so that people can tweet about them, share them on?
Yeah, we will be sharing them, and we will be using them as well during presentations going forward. So we're really grateful to Alex for producing those. They're brilliant.
Okay. We're slightly ahead of schedule, which is actually always rather nice, I think, when I'm attending something, to not be late. Sophie, is there anything else, apart from thanking everybody, which I'll do in a minute, is there anything else I need to say or do?
No, you're only 2 minutes ahead because the agenda took us till 12:15, even though we have the event scheduled until past. So you've done an excellent job at sharing, and Kamlesh too. Thank you very much.
So thank you to all of our panel members, both the panel of researchers, but also the panel of policy makers that I didn't really thank properly at the time. So thank you for giving your time to doing this. Thank you to Lucy. I know she's gone, but still grateful that she came along. I hope this has been useful. I think for me, it's really good that we've managed to focus on the positive. So I think what's going to be most useful are those list of facilitators that you highlighted in the groups, and also those illustrations which we can use to really remind me of some key messages in how we get the stories across in ways that are going to be useful. So thanks, everybody. I hope you enjoy seeing the YouTube video, that you have the transcript as well if you want to look at that rather than watch something again. And I'm sure I'll see some of you at various MLTC related events in the future.